Glacier Bank's totally free checking saves you both time and money. Visit your nearest Glacier Bank office today. There's a convenient location near you. Glacier Bank, member FDIC, and an equal housing lender. And today we're going to talk about them bones. Logan Health Orthopedics and Sports Medicine nurse practitioner Michael Heilman.
Good morning, John.
Good to have you with us today.
Good to be back.
So, I guess let's start talking about what should you do, for example, if you mess up your knee.
Well, very common injury we see here in the Valley. And sometimes the question is, what imaging do I need? Do I need to get an MRI? Do I need to see a provider? All those things are likely going to help. Good information from that advanced imaging is possible. If you have those resources to get that, sure, that's a great test to have done to see what's going on in your knee. However, it's probably more likely that a simple evaluation, a physical exam, an x-ray, a good history taking would likely be the first thing we do to start your treatment and whatever the injury may be it an ACL strain, a collateral ligament strain, any number of injuries to the knee that are common in skiing and hiking and those things that we see people in the Valley are for.
The knee is a very complex joint. It can do so many things, but it can't go sideways.
Right. And sideways is a lot of things that we make it do. We try to, we jump, we ski, we climb on irregular ground. So it is a thing that we force it to do. So good stability is the key. Good strength in the quadriceps, good strength in the hips. All these things that we can focus on while we're healing a sprain or injury to the knee.
Mm-hmm. How do these usually happen? What kinds of accidents do you see the most?
So I think skiing is a good example of a typical injury that leads people to see us wondering if they need surgery on their knee. When that knee is forcefully, when your ski grabs, the outside edge of your ski grabs and your knee goes forward on your lower leg, then those ligaments inside the knee are stressed or strained or tear. So that is one of the mechanisms, twisting and then that forward motion, that translocation of the femur on top of the tibia or the lower leg.
Now, when I was skiing a lot, they would always tell us that your knee should be like a shock absorber, absorbing the movements and everything. So you lean back and keep your legs straight from the knee down. That's what we were told to do, and then we could bounce. You just bounced up and down with whatever you ran into.
Sure, yeah, that bouncing, though, I think leads to long-term destruction of that cartilage in your knee.
So I thought I had the answer.
No, I think that's very common, but I think the way we're designed is that our shock absorber comes from our thighs, our calves. So those muscles, if they're toned properly, they're stretched properly, then that force isn't transferred into those ligaments, be it the Achilles tendon or the ACL, the PCL, those ligaments inside the knee that we find injured frequently.
Well, the way that we ski these days, when I was a kid and learning how to ski up a big mountain, we had leather boots, and the kind of injuries we saw were more like sprained ankles, broken ankles, that sort of thing. But we've stabilized that part with these big ski boots now, and so your foot is literally stabilized right together with the ski. So I guess it has to move further up the leg?
Up the chain, yeah. When back 30, 40 years ago, when those new boots and bindings were being introduced, then we'd have these fractures in the tibia or on the leg. But now the bindings are better. The bindings, if they are tuned properly, the binding will release. But if the bindings aren't, and then that force is now further up the leg into the knee, that's when we see those sprains. In theory, that's how that mechanism works.
I remembered in the Olympics this last year that the skier was down, and she really did a number on her. But, I think probably those Olympic skiers kind of tighten everything down a whole lot more than, the rest of us would in tuning our bindings.
Oh, I agree 100%. And actually, it may be, too, that they are more prone to more chronic injury. So I think you're referring to the skier that was catastrophic, the injury that she had.
Yeah.
But I think she probably had prior injuries that, and she skied through. Many of our athletes now are doing that more and more. So, that's another thing that we can help with in sports medicine. That's what sports medicine really is. It's getting an athlete to train themselves to prevent injuries as well as heal properly from them.
Well, right now we're not in the ski season, so what sorts of things do you see now that people come in and say, what were they doing when they hurt their knee?
That's the key. It's really getting that story, that mechanism of injury. And talking to Judy, you're a big fly fisherman. Even fly fishing, walking on unstable ground and rocks and getting in and out of the water. We see hip, knee, ankle injuries all the time. Many times it's just a sprain, something we just need to immobilize and allow to heal and rehabilitate with good physical therapy.
Yeah. Okay. So let's talk about when you should come to see a guy like you.
Well, anytime you've got an orthopedic problem, a bone or joint problem that is a newer problem, we're happy to see you in our clinic, our walk-in clinic. No appointments necessary. We do deal with other chronic problems, such as arthritis, but many times if it's a problem that a patient has had for a long time, an appointment is sometimes a better thing to set up. And during those appointments with our surgeons or our total joint specialists, we could stage those injuries better and treat them more properly towards a chronic condition, be it a joint replacement, joint injections, those things.
So is it always about the knees?
No, not at all. I mean, hips and ankles and wrists and hands and, the spine is something that we don't see much in our clinic. We do see people with spine problems that are radiated into the hip, or neck problems that are radiated into the shoulder that we do evaluate for those joints. But we're developing a good relationship with the Spine Resource Center so that those people with spine problems can be seen quickly.
Well, the human body is just all interconnected, isn't it?
Yeah, yes, it is.
You mess with one thing, you'd likely be messing with something else.
Right.
Michael Heilman is our guest today, and we're talking about orthopedics primarily. And I want to get a little further into the knee injury thing and how you diagnose this, how the diagnosis works, and what kind of treatments are available. We'll do that after this. And today from Logan Health, Orthopedics, and Sports Medicine, we have nurse practitioner Michael Heilman. How far does a nurse practitioner get into these treatments before the doctor gets involved?
That's a great question. Initial evaluation, history, physical exam, x-rays, MRIs, those tests gather information that help us decide, is this injury or problem a surgical problem or not? And that's a fundamental difference. The surgeons, they deal with those injuries that need surgery or being repaired, an ACL, for example, with the knee. However, they're also very much more highly skilled and trained. They can definitely see patients for the same things that are non-surgical and direct non-surgical therapies. But with the demand and the increase in orthopedic need in the Valley, most of what our surgeons are doing is surgery. So, but they're great consultants for us. They're available all the time when we see patients and there's a question on what we're seeing, what this patient needs. Our surgeons are available for us all the time to give their advice on MRI interpretation, x-rays, and specific patient concerns.
So that's kind of how you diagnose the whole situation. You start the whole process, and then you consult until you come up with an answer.
Right. And common things occur commonly. We see lots of people for injuries where we can treat them, and our plan when they leave our clinic after they may have had x-rays and a physical exam history and be prescribed medications as needed or other tests. If the plan is not working over the course of weeks, then usually a follow-up is with a more specialized surgeon or PA/NP.
This conversation just got me thinking about how we used to put up with stuff that we don't put up with anymore, primarily because we have remedies for it. But remember when people used to say, I've got a trick knee?
Yes.
I'm not even sure what that was.
Well, a lot of times I think we're dealing with, a trick knee, it's like a locking or catching, or it's feeling like it's giving out. And that's probably a trick knee. Oh, my knee just gives out, or my knee is locking or catching. That is a sign of a couple of things. It could be a torn meniscus. It could be just degenerative disease, or the cartilage is worn and now there's fluid in the knee, and that makes you feel like your knee's unstable. So determining whether or not a knee is stable really on exam and needing surgery for it, or it's a knee that's just telling you it's unstable, is something we simply can do in the clinic with x-rays.
And that way we don't have to put up with that pain and with that instability.
Right, and then the instability is it's something that's neurological in part, and physical therapy and strengthening is how we deal with that. So our brain understands that knee is stable. We just need to exercise it and strengthen the quadriceps and have some flexibility in the hips and lower back.
So what kind of treatments, short of knee replacement, can we do?
Well, for early stages of arthritis, we treat the inflammation, the pain, with corticosteroid injections, oral, non-steroidal anti-inflammatories, physical therapy to strengthen and stretch. Beyond that, when there's more advanced and we want to preserve that joint space, we can use other treatments. There are solutions that we inject into the knee that provide a lubricating source. Hyaluronic acid is one of those, or a main form of those, many different trade names, but that's something you can get injected into your knee now that helps lubricate that knee and preserve that joint space before you need to consider getting it replaced.
That sounds painful.
Well, that's done under a local anesthetic.
All right.
It's a very simple procedure that we don't do in the walk-in clinic, but that's a good example of something you would schedule with a provider in our total joint service.
But you can do all of these things, and at some point, though, probably that's not going to hold up.
Right. At some point when we're finding that your pain or your symptoms or your trickiness of the knee is still happening, then we have a conversation with the help of x-rays showing the advancement of the narrowing of that joint space, and we start talking to you about how we can likely return you to doing what you want to do with a knee replacement.
We've mentioned arthritis, and this is getting to be something that people, certainly in their advanced years, are really dealing with all the time. What can you do about that?
Well, arthritis is, and there is a lot of emphasis now on inflammation in the body and what it is that we're eating and what it is that we're doing that may cause this natural process. That is a process of healing to some degree. But how do we suppress it? How do we make sure that it's not worse than it needs to be? Sometimes we do that with diet and exercise, but other times, as I mentioned, we need to take medications that'll help suppress the inflammation, and corticosteroid injections to suppress the inflammation. But it is an ongoing battle with a mechanical part, wear and tear, that is a natural process. So sometimes real natural things can help that slow that process down.
You know, I just got to thinking we haven't really talked about anything above the hips. What about arm injuries? What about hand injuries? What about shoulders?
Boy, those are the injuries we usually see on Mondays after someone's been out and about in the weekends. Not to say the knee isn't a big weekend thing, but hand injuries with home hobbyists and power tools, and the athletes and their elbows, and certainly shoulders from throwing sports. We see all those frequently. The treatment course of those is not a whole lot different than the knee problem. I mean, these joints, certainly we see them more commonly in different age groups, but I think the athlete with a shoulder problem is a common one, where we wonder, does this person have a torn rotator cuff? And many times a good physical exam can determine that. MRI imaging is also good to help decide, does this person need a reattachment or surgery in the shoulder? Then we wonder, what will they tolerate the recovery, which can take a little bit longer than many of these athletic people would tolerate. So many times we make that decision, does physical therapy strengthen that joint and return it to its stability versus going in arthroscopically and repairing something we see on MRI.
Recovery, that's a key portion. And let's talk about that in depth after this. And from Logan Health Orthopedics and Sports Medicine, nurse practitioner Michael Heilman is with us. Okay, so you can do some pretty amazing things to help us live our best lives, but one of the things we have to do is recover.
Right, and thanks. Yes, we can do some remarkable things, I think, in orthopedics. But you're right. It all boils down to the patient and the patient's motivation to get better. That's why sports medicine is so popular. You're usually dealing with athletes that know that their body is something they can train to get better and get stronger. But today, I think we're looking at folks that we consider athletes that aren't necessarily on the pickleball court or skiing black diamond slopes or competitively athletes. These are older adults that are walking a lot, doing things. We like to think that they have an athletic component to their recovery. So it is a lot in convincing someone that they need to do something to get better rather than just heal passively. So yes, I'd say recovery does involve some more personal motivation.
What do you have in line for being active in your recovery?
Well, many people can be self-directed. They can take a list of exercises to fix a shoulder or knee or hip problem and strengthen it and stretch it. Other people, it might be better to see a physical therapist, and there's plenty in the Valley, plenty of physical therapists in the Valley, very qualified to help direct you and in essence, be an athletic trainer to return you to your desired activity level. So the recovery means usually exercising or movement. It's all in movement and good movement, the right movement, and strengthening.
You sure don't want to keep doing the things that got you there in the first place.
Correct. That's the difficulty when you're dealing with an athlete that is strong and you tell them they need to strengthen their joint. It's not received the same way.
Yeah, I can see that. Michael, what sorts of training and preparation did you have to do the work that you're doing today?
Well, my initial training as a nurse, an RN, was the fundamental part of being a nurse practitioner. Then the advanced training in a nurse practitioner program gives you a family practice or specialized background. And then focusing in athletic or sports medicine and orthopedics was done over time in various jobs that I've had in surgery and in clinic settings.
So in other words, this has kind of been an ongoing process for you.
Yes, I've been a nurse practitioner for 27 years, and primary experience was in emergency medicine, and most of that was seeing orthopedic-type patients in the emergency department.
Did you ever think, gee, I could be a doctor?
Yes and no. I mean, I think I have the advantage of not going that route as much as I would have benefited from it, but I think that it's certainly more focused than what I do.
Mm-hmm. You get to do more variety is what you're saying, huh?
I think the career path I chose has allowed me to have a variety of other opportunities.
Mm-hmm. Yeah, and you didn't have to do the cadaver thing.
Well, there were some cadavers or other.
Oh, there were?
So yeah, and most training I think now is either virtual cadavers or real cadavers.
Really?
Yes.
All right. So let's talk about when a person should seek help. You say it's usually on Monday, but at what point, what's the best thing to do? If, let's just say, for example, you've been out hiking all weekend long and you got some soreness going on that is not associated with just, sore muscles.
Sure. So if you got a swollen swollen joint, ankle, knee, shoulder, wrist, whatever, that's something that, if you're at the point where you've tried what you've normally tried, our clinic is set up to see you urgently at our walk-in clinic, where we'll do an evaluation, which usually includes x-rays. X-rays is a fundamental test that we usually do when someone has a joint problem. Rarely does it not give us a little bit of information. A good physical exam and history, and then agreed upon plan to get better, which may take weeks, it may take days, it may take longer than that. And it may have a plan component of that to see a physical therapist or just on your own healing. And if a agreed upon time frame is you're not feeling better, then we usually have planned follow-up with one of our specialty providers.
So where's your clinic?
We're at 111 Sunnyview, right there on 93 as you enter.
Oh, you're right on the corner there.
Yep, in the brown building.
You're the first people we see when we head into the hospital complex.
Right.
Okay. What a great conversation this morning. You sure answered a lot of my questions, and I think a lot of folks will be a little less tolerant of the pain that comes from joints simply because they don't have to put up with it anymore.
Right. And no time than now to get better and start working on it. So we're available for you.
Michael Heilman, thanks so much.